Graves-Basedow disease is one of the most common autoimmune diseases. The commonly used eponymous term Graves' disease recognizes the Irish surgeon Robert James Graves as the first physician who described few cases with thyroid enlargement and cardiac palpitations associated with it. Karl Adolf von Basedow, a German doctor in Merseburg, published his description of the same disease few years after Graves' original publication. The disease was characterized by the so-called Merseburger triad: tachycardia, goiter, and exophthalmos. His name is also linked eponymously to this disease, particularly in Hungary and many countries in Europe. This disease, also known as diffuse toxic goiter, is an autoimmune process characterized by diffuse hyperplasia of the thyroid gland and excessive overproduction of the thyroid hormone. The major pathogenetic factor is the presence of autoreactive lymphocytes and plasma cells, which secrete IgG autoantibodies to the TSH receptor. These antibodies bind to and activate the TSH receptor on the thyroid follicular cells, mimicking the effect of the real TSH molecule, thereby stimulating thyroid hormone synthesis and secretion as well as thyroid growth. Microscopically, hypertrophy and hyperplasia of the cells can be demonstrated, which eventually lead to gross enlargement of the organ, leading to diffuse goiter. The clinical triad of Graves-Basedow disease involves hyperthyroidism, which is a clinical syndrome when there is excess thyroid hormones in the circulation. Graves' orbitopathy, also known as ophthalmopathy or Graves' eye disease, and the third one is localized infiltrative dermopathy, sometimes called as pretibial myxedema. The extrathyroid manifestations are at least partially caused by activating TSH receptor autoantibodies, which are also present in the retroocular connective tissue and in the skin. Graves-Basedow disease predominantly affects young women, and it has a peak incidence between 20 and 40 years of age. Like in Hashimoto thyroiditis, genetic factors are important in the etiology of Graves' disease, and many patients have other autoimmune diseases like type 1 diabetes, systemic lupus erythematosus, rheumatoid arthritis, pernicious anemia, and so on. Clinically, almost all patients will exhibit signs of thyroid enlargement and hyperthyroidism. Laboratory findings include elevated free T3 and T4 levels and a markedly decreased TSH levels. In addition to signs and symptoms of hyperthyroidism, in many cases infiltrative orbitopathy, also called ophthalmopathy, develops, leading to symmetric bulging of the eyeballs from the orbita. This is called exophthalmos. This manifestation caused by autoimmune reaction against the retroophthalmic connective tissue, leading to swelling of the affected area and bulging of the eyeballs. This can be also demonstrated by magnetic resonance imaging, shown on this image. Relatively rarely, pretibial myxedema develops, which is caused by fibroblast proliferation and increased glucosaminoglycan synthesis of the dermis, leading to localized nodular indurated lesions mainly on the extensor surface of the tibial skin. Grossly, the thyroid shows diffuse enlargement with increased weight. The normal weight of a thyroid gland is approximately 25 grams. The surface is relatively smooth and the parenchyma has a soft and meaty appearance. Microscopically, the most characteristic and striking histological finding is the diffuse non-nodular hyperplasia of the follicular epithelium. In this low-power field, I want to show you this feature, comparing it to the normal non-hyperplastic thyroid parenchyma. On the right, you can see the hyperplastic thyroid gland, which is a sample from a thyroidectomy surgical specimen, and on the left, the normal one. The first thing you notice is the nearly absent colloid in this low-power view. If we slowly scan through the two slides at the same time, the difference is striking. The normal thyroid tissue is composed of more or less uniform-sized and shaped follicles. lined by a monolayer of mostly cuboidal epithelium. And in each and every follicle, there is the homogeneous pinkish colloid containing the protein thyroglobulin. This protein stores the thyroid hormones, which are liberated into the bloodstream as thyroxine and triiodothyronine T3. In normal conditions, the colloid content is relatively abundant. In cases of Graves-Basedow disease, where there is a constant TSH receptor activation because of the activating autoantibodies, there is a very high utilization of the colloid, and the amount of colloid in the follicle is reduced because it is synthesized, secreted, iodinated, and resorbed too rapidly to accumulate. Here in this field, the depletion of colloid is seen compared to the normal thyroid. As the cells are activated, they basically suck out the colloid from the lumen, and we can see this process as the abundance of resorption vacuoles and the so-called scalloping at the interface of the colloid with the follicular cells. The constant TSH receptor activation causes enlargement of the cells. They become tall and columnar compared with the more flat and cuboidal normal follicular cells. Many follicles show papillary infoldings within the lumina caused by the crowding of these cells. These papillae are generally simple and non-branching with limited projection into the central space. Be very careful not to misdiagnose this as a sign of papillary cancer. The clue in the differential diagnosis is the lack of typical nuclear features of papillary carcinoma. Here is another area showing these papillary infoldings with no nuclear atypia, no pseudo-inclusions, and other features suggesting cancer. I also want to highlight the rich vascular supply of the gland with numerous erythrocyte-filled capillaries in the interstitium surrounding the follicles. Other areas show more dilated follicles with varying shapes and sizes. Some of them have empty lumen or more paler colloid, but some of them may have darker colloid, but most of them show the prominent resorption vacuoles and the scalloping phenomenon. This focal heterogeneous appearance is usually caused by the drug treatment prior surgery. Patients with Graves-Basedow disease treated conservatively with anti-thyroid medications like metamizole and PTU, propylthiouracil, which decrease the hormone synthesis in the follicular cells. Another potential non-surgical treatment is radioiodine therapy. This treatment utilizes the fact that the uptake of iodine by hyperplastic cells is very high. So by ingestion of the locally harmful radioactive iodine, those cells will undergo apoptosis, which are the most active. The local radiation effect basically kills the most active cells, the iodine accumulating cells in the thyroid. Important to note is that these drug-induced changes are mostly visible in the histological slides of surgical specimens, because surgeries of previously non-treated individuals are very rare. These changes mainly appear as inhomogeneity in the hyperplastic changes. Some of the cells show more suppression because of the effects of anti-thyroid medications, but some of them are not. Radioactive iodine may cause radiation-induced nuclear atypia, which sometimes may mimic atypia associated with carcinomas. Although it is an autoimmune disease, there is usually scant, not prominent lymphocytic infiltration in the interstitium. If you scan through the specimen, it is almost entirely absent. Only small areas show lymphocytic aggregates, but no secondary follicles are visible. Other times it may histologically overlap with Hashimoto thyroiditis, with more pronounced lymphoid infiltrates, even with more or less lymphoid aggregates, and sometimes germinal centers as well. So to summarize Graves-Basedow disease, it is an autoimmune disorder characterized by activating anti-TSH receptor autoantibodies causing diffuse goiter with hyperthyroidism, ophthalmopathy and dermopathy. Histologically, we see diffuse hyperplasia of the parenchyma with decreased colloid content. Some follicles may show papillary infoldings without cytological atypia. The interstitial lymphocytic infiltration, contrary to Hashimoto thyroiditis, is usually scant or non-existent. Drug-induced epithelial changes like nuclear atypia from radioiodine treatment is usually seen. Thanks for watching this video and goodbye.